I'm going to kind of share with you this morning some of my personal experiences over the course of a career that began before almost everybody in this room was born. And also share some of the research findings. I'm not going to go into great detail, but just to kind of illustrate the sorts of things that I've been involved in. I first have to point out where lots of research support has come from, including the program project grant that Richard mentioned. If I can get it renewed one more time, and we're going to be putting it in May 25th for another 5-year period, I will be 80 when it ended. So as long as it's fun, I'm going to try to keep going. Work like this doesn't happen without many, many colleagues who do the work. And as I've often said, I really feel more like I really don't know how to do anything. I can do a chi-square, but past that, it's too beyond me. And I kind of feel like an orchestra conductor, a symphony orchestra conductor, who doesn't know how to play a single instrument in the orchestra, but does have an idea about how all of them are supposed to sound as they go along. I do need to disclose that my wife, Virginia, and I own a company founded several years ago called Williams Life Skills, and I actually do hold a use patent on the serotonin transporter promoter polymorphism, which will never, thanks to the Supreme Court, generate any income, I'm sure. So, I want to start out with a few words from Robert Frost from The Road Not Taken. 2 roads diverged in the yellow wood. I suspect most of you remember this. Well, in the summer of 1959, I had already made a choice between going to Duke, where everybody at my Eastern Shore, Virginia public high school thought I should go, or Harvard, where some guys at Boys State said, if you're as smart as you think you are, you'll go to Harvard instead of Duke. And so I applied to both and got into Harvard. That summer comes a letter announcing a freshman seminar program. It will be small, only 10 to 12 people. It'll meet every week. You have to write 1 paper a week, which gets you out of the freshman composition, English composition course. It counts for 2 courses, so you only have to take 2 other courses, and you get a stack pass to Widener Library, which I didn't appreciate at the time, but came to when I saw people lined up in those days waiting to get the work-study students retrieve their books. I was interested in 2 of them. One was taught in political science by a fellow named George Bundy. How many of you know who he was? He ended up being the National Security Advisor for President John Kennedy and a major architect of our disaster in Vietnam. The other was a behavioral science taught by George Goethals, whose grandfather, George Washington Goethals, has a bridge in New York area named after him. If I'd gotten into both of them, I would have chosen the political science one because I'd been a debater in high school and was thinking, well, I'm going to be a lawyer or a doctor and so forth. And if I had gotten in both of them and chosen that one, you would not be seeing me up here talking to you right now, quite confident. I might be in disgrace after having served into the Kennedy administration. Only made it into one, behavioral science. The first paper topic that George gave us, as we were all 12 of us sitting there, okay, your first paper assignment's the mind-body problem. Sitting there looking at Joe. And he had chosen a very representative group for this seminar. I was the token poor Southern white boy. We had a daughter of a Greek shipping magnate. We had a very proper Bostonian, Henry Lowell Mason III, who's now deceased, bless his heart, and various others. So I wish I could tell you that I finished the assignment. I'm still working on it. And what you're going to get this morning is a progress report on that patient. I majored in social relations, or SOC-REL. My senior thesis was the influence of superego content upon ego functioning. I wasn't unambitious even back then. In 1963, I married Virginia Parrott, and this is very important for you all because you make choices, and the partners you choose can, as I will illustrate in the rest of my talk this morning, have an impact on your career. Went to medical school at Yale, continued to do psychophysiological research, interpersonal interaction effects on blood pressure. People, when they're interacting personally, sharing personal aspects of their life, blood pressure goes up more than when they're doing a word association test, unless they do the word association test after they've done the personal interview. Did an internship and residency in internal medicine, so I'm a real doctor. You would not want me to be your internist at this point, though, I'm sure. NIMH for 2 years, more psychophysiology, brain mechanisms. I have a paper, I'm a co-author on a paper showing that bilateral lesions of the locus ceruleus changes the blood pressure reactivity of rats to shock-induced fighting. How's that for neuroscience? Joined the faculty at Duke. That's another choice, where you go. I was looking at Pittsburgh with Al Shapiro. I was looking at Rochester with George Engel, who were very anxious to get me there. And I was looking at Duke. And it turned out Duke had the real best offer at the time. And since it was in North Carolina, which is where my family's from and so forth, went there. And had been there ever since, doing research on psychosocial factors in CHT. Here are some of the psychosocial risk factors I, along with others, have helped to identify, particularly the fact that when you have more than one, it's not just additive, but worse. The usual suspects of the biobehavioral mechanisms I've spent a lot of time working on. Back in 1986, I put together this model to kind of guide my research. And you'll notice that in 1986 I had genes. In the spring of 1962, I had finished all of my pre-med courses except biology, inorganic, organic, physics. And the last one was biology I had to take for my pre-med. The one I was planning to take was Natural Sciences 5, one of the general education courses, kind of like biology for non-biologists sort of thing. And it was taught by George Walt, who was the discoverer of rhodopsin and the visual pigments. Visually, I know won a Nobel Prize for that. And I was looking so forward to taking that course in the fall of '62. Wall lectures were works of art. I mean, they were just inspiring. When I went to sign up for it, I was told you can't take it. I said, well, it's filled this fall. You can take it in the spring, but it's filled in the fall. I said, you've got to be kidding. I'm a senior. This is my last pre-med course. You've got to let me take it. No, there's another intro biology course you can take, genetics. Any of y'all have taken genetics, done those crossover problems and that sort of stuff? I finally learned how to do them, but anyway. Well, about October the 12th, we come in class one day, and on the blackboard at the front of the room is written, Dr. Watson has just won the Nobel Prize. I got my genetics introduction from Watson and Crick. So I think I probably got imprinted a little bit to genetics. But it was a long time, not until 1986, that I began to seriously think about it. And even then, my understanding was that if you wanted to do research on genetics, you had to have 5,000 monozygotic twins, 5,000 dizygotic twins, with 2,500 of each raised together or raised apart. And then you could come up with nice, elegant statistics that proved that 40 to 60% of any phenotype you wanted was genetic. That was not too inspiring for me. But anyway, I had this idea that the genes had to be in there. Well, along about 2003, Caspi, Moffat et al. Came up with this very famous paper. And of course, during the time between 86 and then, molecular genetics, we could actually genotype specific genes. You didn't need 5,000 twins and so forth to do it. And they found that if you didn't have any stressful life events, your risk of major depression was pretty low, and your genotype didn't matter on the serotonin transporter promoter. On the other hand, if you had lots of stressful life events, it mattered a great deal. If you had the long, despite that, you didn't have any depression, much increase in depression. But if you had the short, it was up to 40%. And this inspired me to say we've really got to now, I've got to now start getting into the genetics. And so worked out this more recent version of my model, where you have genes, environment. They can directly affect what your brain is doing to these various phenotypes. They can interact to affect what your brain is doing, and they can affect each other. Your genes determine, to a certain extent, how you relate, the kind of environment you go to, and your environment can actually change the expression of your genes. And if you don't believe me, just Google me. You'll find out. But we're going from these, the pathway is not directly from genes to heart attacks. It's got to go through all of these pathways. And the genes continue to be actually operating out here, of course, in all of these systems as well. So you can imagine it can get pretty complicated after a while. So what I'm going to do now is quickly run through just some of the findings we've had, just to kind of illustrate what you can get at here in terms of gene-environment interactions. Just to get right down to the real science of it all, we've actually, in one of our first papers, once we did this, we did one of the version before last of my program project grant. We brought in about 160 people and did spinal taps on them to get their CSF so we could look at the metabolites of serotonin. My presidential address in 1993, which was published in '94 in our journal, theorized that brain serotonin levels being low is responsible for the clustering of all these psychosocial and biological and behavioral characteristics that are so bad for you, which I'm not going to show you today. We had a paper a couple of years ago, a little bit longer than that, in Psychosomatic Medicine, actually documenting that. Look that one up. But in any event, here, cerebral spinal fluid levels of 5-hydroxyindolacetic acid, 5-HIA, is considered crude, but they measure a brain serotonin turnover, the higher it is. And we found that the serotonin transporter promoter genotype was associated with this, but in a way that varied as a function of race ethnicity. African Americans in our sample with a short, you see they're very few, but nevertheless had very high, and Caucasians very low. And women also had high, and men very low. Significant gender interaction here too. So here's something that's basic. This is not an observational thing. You know, this is HPLC measures of your brain 5-HIA levels. We found more recently, and Bev Brummett at our group is one of my leading paper producers, and if you want to get ahead with your mentors, the more papers you publish for his or her research, the more likely you are to succeed, I can assure you. But here we're looking at transporter genotype and depressive symptoms. Now you notice, remember the Caspi thing, it was long, stress didn't raise it, short it did. Well here, we're looking at a group of caregivers of a relative with Alzheimer's disease or matched controls for SES, race, sex, everything. And in the controls, your genotype had no effect on your depressive symptom levels. However, in the caregivers, not surprisingly, your CSD score was higher, actually in the clinical range overall. But in women, it was the short who had the higher. But in men, it was the long. Now, if you ever do research in genetics, one of the things you're going to get told is, oh, that's fine, but let's see you replicate that, Buster Brown. Yeah. There's the replication. Not a perfect replication with another set of caregivers and controls, but in a way, interestingly enough, taking a measure of SES when you were a child. And if your father had more than 12 years of high school, of education, zip, genotype effect. However, if he had less than 12, and this is father only, mother didn't show this effect, men, long high, women, short high. These data, that slide, looks almost too good to be true. You hardly ever see anything that is as clearly documenting what I'm talking about as that one. Another finding that we had using our caregiver control sample in the women was that it's not that the genetic, you have a bad gene that's bad for you. Whether the gene is bad or good for you depends on the environment in which you are. So in this caregiver study, if you were long, it didn't have any effect on your depression symptom level. However, if you were short and a caregiver, you had a CSD score of 18. That's pretty high. But look at the controls with the short. 4. And just to show you that we can replicate that, in this paper we did with Jay Belsky using our data and some other data, you've got to take the environment into account. Because if you didn't take the environment into account, you wouldn't see zip from the genotype. They would cancel each other out. This principle also applies to biological phenotypes. Here's ApoE, apolipoprotein E, plays a big role in lipid metabolism. SNP RS43, 439, 401 has been found in a big European GWAS, 20,000 people. The the TT genotype was associated with lower triglycerides in a large European GWAS sample, whereas the C carriers were higher. In our controls, that's exactly what we saw. But in our caregivers, instead of being low, they were high on triglyceride. What's going on here? What's accounting for this? And any day now, I'll be able to tell you whether or not it's methylation. We're doing methylation on, we've got a whole genome methylation chip going. We'll be able to tell you whether the TT caregivers have a methylation pattern that differs that account for this effect. We were able to replicate that effect in an independent sample of Danish men, showing that the TT had lower, in this case, fasting glucose than the C carriers, whereas in the men with high stress, it was higher glucose. So, more recent, accurate version of this, we're now wondering whether we can show that these gene-environment interactions that affect these phenotypes give rise to increased risk of heart disease or more adverse clinical course. And here's a paper that, again, Bev Brummett published a couple of years back, in which we found that the 5-HT2C receptor, SNP, 6318, the 2C receptor is the receptor in the paraventricular nucleus of the hypothalamus, which when you're stressed, the 2C receptor gets stimulated by serotonin that's released during stress, and that causes CRH to be released to turn on your HPA axis. Well, the people in this sample, this was men, it's an X chromosome gene, so men have one copy, women two. We only had 3 women with the CC genotype on this, which is the bad version. So we didn't include the women in this. But the men who had the C allele had a cortisol response to a stress protocol, lab stressor, that was 2 to 3 times bigger 2 to 3 times bigger than those with the G allele. And this is a functional SNP. The C gives you a serine at position 23 and the G a cysteine. So does this C allele predict anything in a sample of heart patients we had at Duke, about 10,000, who are being followed and who we have their angiogram data and so forth? Yes. In fact, in the Caucasians, we looked here in this paper that just came out, PLS01, those with the females with the CC genotype with 2 serines and males with the C carrying the C had a significantly higher risk of MI or death over the follow-up period. And if anything, the women had a bigger effect if they had the CC, even though there are fewer of them. And when we combine the women and the men, the C carrier men and the CC women had a 5.9 average follow-up year risk of mortality or MI that was 38% higher than the Gs. 38%. I think most of us would agree that's clinically significant. And we went back when we saw this and looked at the 3 women in the earlier study who had the CC, and even though there were only 3 of them, their cortisol response was statistically significantly higher than the 850s G carriers. We're now getting fancier in this, and we're doing path analysis. This is taking advantage of the MESA sample, multi-study of atherosclerosis, and just to make a long story short, in this VAL BDNF, brain-derived neurotrophic factor, VAL-MET polymorphism, in the VAL-VALs, the path from depression to smoking and depression to BMI is significant, but in the MET carriers, it's not significant. And furthermore, in the VAL carriers, since they have parotid and intermediate thickness in this sample, the path, the indirect path from stress to depression to smoke to BMI to CCIMT is significant. It's not significant in the MET carriers. The smoking path is not significant when we had the BMI path in the moment. And there's a 12% higher significant mortality in the VAL people in our clinical cath check sample. This paper is being prepared for submission, so it's not citable at this point. So, all this is very interesting, but so what? Why are you doing all this? I'm a doctor, and I do research to try to find findings that can help me to improve people's health and prevent disease. So could we intervene by picking people on the basis of their genotype? This is a slide that illustrates one of my important life choices, my choice of Virginia as my life partner. And Virginia has a PhD in intellectual history. Her thesis was the impact of World War I on surrealism and quantum philosophy. She's real smart, a lot smarter than I am. And she put me through medical school after she got her MAT in teaching, and I put her through her PhD program at Duke. And so in the early 90s, I'd written a paper on a book on hostility called The Trusting Heart, which was meant to make everybody realize that hostility is bad for you and so forth. But it had this much science and this much, here's what you do about it. And it got very good reviews, but didn't sell a lot of books. And I realized that I needed to make it more this much science and this much what you do about it. And so I convinced Virginia to quit her doctor at locum tenens headhunting job because there were no history jobs in 1990 when she had gotten it back in the 70s. And so we partnered up and wrote a book called Anger Kills. And that book, once we were on Oprah, did very well, and led to another book called Life Skills, in which we developed this life skills approach that involves these 10 modules. Very structured. It's very similar in some ways to Mike and Tony's CBSM and other CBSM, Sue's CBSM, so forth, but it's very structured. And it's not both therapy, but it's training and so forth. The way you evaluate your thoughts and feelings, this is CBT for dummies. Something negative happens, what are the objective facts? It's important. If it's not, you use these deflection skills. If it's important, appropriate, you keep going, use these action skills. Sometimes you're upset means you need to do something. Otherwise, Rosa Parks would still have been riding in the back of the bus. Other times you're just getting upset over something that's trivial or not changeable, or when you really think about it, not appropriate. So, this is the Mandarin version. This is the Portuguese version, Deutsch version, and the Hungarian version. So we've got this going a lot of places around the world. We have several ways of delivering this, including life skills video that we've evaluated in a caregiver study published in Psychosomatic Medicine. You can look that up. Just to give you some ideas of the kind of findings, back in '99, Karina Davidson's student, Yori Gidron, did a clinical trial of an earlier version of our program at Dalhousie University in high hostile male heart attack victims. And in those who got the training in the workshop, it went down in 2-month follow-up, their hostility was down more. And this is not self-report, this is blind observer ratings of a structured interview assessment. Also, their blood pressure went down. And when Karina did a follow-up sometime later, those who got the hostility control training had about a fifth the number of days in hospital over 6 months following their discharge. And the average savings, Canadian dollars net per patient, net taking away the cost of delivering it, was $4,000 Canadian. Here's one other study I'm going to summarize, to go over quickly. This was George Bishop's study in Singapore, where he had Chinese, Malay, and Indian men who had cabbage surgery. No other psychosocial or inclusion criteria. Not selected for depression or hostility or anything, or low social support, just puts you in. 6 2-hour sessions of our life skills workshop delivered by people Virginia had trained. The usual care group got an hour lecture on stress and tips about stress management, assessed a whole bunch of things, follow-up, post-intervention, 3 months. Depression went down in the life skills group. Trait anger went down. Perceived stress, even though the controls started higher, they still drifted up, whereas the life skills group came down. Not only bad stuff went down, but good stuff, like satisfaction with social support, went up, and satisfaction with life went up in the life skills group. Well, these were questionnaires, and you've been so nice to us, we're of course going to answer the questionnaires in ways that, show we appreciated all the trouble you took. You can't fake your blood pressure. And you can't fake your blood pressure reactivity to stress. And indeed, both groups were 22 to 26 millimeter increase in systolic. That's a pretty hefty increase in blood pressure. Following, the control group drifted up. 3 months afterwards, the life skills group was down to 11. Now, one of our findings, also published in Psychosomatic Medicine, was that the long allele of the transporter was associated with larger blood pressure reactivity to stress. And it's also been found in large population samples to be associated with increased MI risk. So here's long allele, increased blood pressure reactivity to stress, increased MI risk. Here's an intervention that reduces your blood pressure reactivity to stress. So one of these days we're trying to, if any of you all would ever like to do a large, simple trial in post-divide patients, we'd be happy to work with you. Others have found, using similar cognitive behavioral stress management interventions, that as Christina and Neil and a bunch of others in women who had CHD, that those who got the cognitive behavioral stress management small groups, very similar to our program, had a threefold protective effect, odds ratio of death 0.33. And also, Gullickson et al. Had a similar showing clinical benefit of a similar sort of intervention in men and women patients with coronary disease. So not only does life skills sorts of training reduce the phenotypes that should put you at higher risk, but here's evidence, small clinical trials, that this kind of intervention in small groups can really affect clinical course. Now what we need is, of course, a big clinical trial to be. In 1977, there were 16 studies showing beta blocker therapy post-MI. 9 were positive, 6 were negative, and there was a big debate, is it good for you? Finally took the enriched, big, definitive trial to show that it reduces your MI risk by 23%. So, just our Chinese work, this is in Chinese medical students, and over here on the left is the group that got life skills training using the Chinese version, and they did all better. So, to conclude, the road not taken. I shall be, last stanza, telling this with a sigh, somewhere here, ages and aging hence. 2 roads diverged in a wood, and I took the one less traveled by. And that has made all the difference. And sometimes the choices are not ones you take, but ones that are made for you, like getting into Harvard, not getting into the George Bundy seminar. Thanks very much, and have a few minutes.